We have the go sign. Hello, I'm Ed Hafner. I'm here to introduce Dr. Summerpal Kahlon, who's with Edifecs as the Chief Medical Officer. And the topic today is maximizing value through AI, excelling in episodes of care. I find Edifecs very, very advanced, particularly in the clinical exchange arena. And I think it's really exciting to see AI as part of as an add-on. So looking forward to it.
All right, thanks, Ed. So good afternoon, everybody. So I feel like being in this room, I gotta tell you all pop quiz at the end, so make sure you take notes. But no, I appreciate you all taking the time this afternoon, especially with kind of the late room change, and hopefully we'll keep this entertaining for you. So, you know, it's always nice to see old colleagues from Change, and I myself haven't been to WEDI in a few years, so it's actually nice to be back. And, you know, when I talk today about value-based care and episodes of care and how we can apply AI, I really want to start with the idea of value and episodes and what does that actually mean? How does that, you know, drive some positive outcome in healthcare to begin with? And then really layer into that how AI can help us do it, you know, better, faster, more automated in an augmentative way, right? So, you know, if we start with value-based care and, you know, the quadruple aim, you know, better care at a lower cost, better patient experience and provider experience, you know, we think about where AI can help, not just sort of solve things that are value-based care, but really solve things that are all of healthcare. And what I mean by that is, you know, value-based care to me, it's not a separate thing from healthcare, it's the same. If we're doing it right, we're just sort of transforming the things we do every day into a different operating model, and ideally a better way to do it that drives more value and better outcomes like we talked about earlier. So, you know, where I look at this through the lens of value-based care, it's really, can we change things, whether they're value-based care, alternative payment model type scenarios, or even just traditional, you know, health plan provider operations? Can we do things that just make people's lives better using AI as a way to do that? So, you know, I think about prior auth, for example, and we look at EPA as an opportunity. There's ways in that scenario to apply AI in a way that automates that process, makes the rules more consistent. And in doing that, not only do you get more efficient at doing prior auth, but really, you know, when I talk to a lot of friends in health plans, they would say, we don't really want to do prior auth. What we really want to do is decision support. I don't want to be the army of no telling you you can't have this. What I want to be is the informed party who says, I maybe know things you don't because I've done the research, I've got the data, and I want to help you provide better care. Try this instead of that, right? And so, you know, as we look at that journey around, you know, maximizing value and how we can do that using AI, that to me is just one example of a broader opportunity to say, where are the little places that we can plug in to get, you know, better, faster, and more productive as we go. So, you know, the topic of this talk is episodes of care. And so let me start just kind of grounding in what episodes of care are for those who aren't familiar. So episodes of care really fundamentally are a set of definitions that define some kind of service. And that service may be a procedure, so like a knee joint replacement, or a colonoscopy. It may be a particular condition, like a stroke. But really, in the end, what it means is we're using a standard set of definitions, both a clinical definition of, you know, what is a knee replacement, for example, but also a set of codes, ICD-10 codes, that drive towards the idea of the elements that are involved holistically in a knee replacement. So not only the knee replacement code, but kind of everything else that ties into that as potential risk factors, as well as avoidable complications that tie into that, and then adding around that parameters. So definitions of what's the trigger, what says that we've now entered into a knee replacement, or that we've finished the knee replacement, and now we can say we've got this clearly defined, measurable clinical event that's occurred. So, you know, the way episodes of care are used most commonly is around bundle payment programs. Now, talking about standards with a group like this, they're sort of our standards, but not really. And so it is a problem when you start doing analytics and you start really sort of looking at the opportunity to improve care. You have to define what that care is before you can say you've improved it. You have to be able to define it, give a baseline, and then say, yeah, now we've improved it. So Medicare, through its bundle payment programs, has one set of definitions of episodes of care that are pretty well embraced across the industry. Most of the rest of the lines of business and health plans, Medicaid and commercial, they use most commonly something called Prometheus, which is kind of the de facto standard. Although there are a lot of different sort of variations of Prometheus that are out there, Tennessee Medicaid, McKinsey, PACES, that are all kind of rooted in Prometheus, but a little bit different. Where it becomes important is the idea that if you have a standard around that service, that definition that says we're all talking about the same thing, we can measure it in the same way, and then ultimately we're going to write contracts and payment terms and measurements that come around that. So the core use case around episodes of care is, like I mentioned, bundle payment programs, which are fairly ubiquitous, although there has been some question about how valuable they are. And so there's a shift from retrospective to prospective that's occurring, but also this shift to say maybe we need to look at this differently in terms of disease management programs and not just one-off episodes. So when we think about, how we can maximize value using episodes of care, the core use case being those bundle payment programs was really the beginning. So what we've seen in addition to that is a lot of different use cases that have come into the frame that are really more analytics oriented. So, for example, when you're talking about a specialist, how do you measure specialists against each other to say this one's good, this one's maybe not? Avoidable complication rate lower, outcomes and utilization better. Those are the ones that maybe you want to be referring your patients to. Those are the ones that you want to build a network around when you're developing networks. So, as we dig deeper into the analytics behind episodes of care, there's opportunities, again, not just to apply episodes of care in the context of bundle payment programs and alternative payment models, but to even drive that back into core fee-for-service. How do you build an effective network of specialists, whether you're a health plan, whether you're a provider network? How do you as a PCP refer to the right specialist? And sometimes the right specialist, let's say gastroenterology, for example, you want to send to one GI for a procedure like a colonoscopy. You want to send to a different GI for Crohn's disease, for more chronic disease management. And they may not be created equally. That doesn't mean one is bad and one is great. It just means they're good at different things, and you want to be mindful of where you're sending people, right? So, all that really is to kind of give you that rooting in episodes of care and what is that, and, why should you care to some degree, right? So, as you move forward off of that, again, a lot of the bundle payment programs, contracts are built around that, measurements are built around that, and there's a transparency component that needs to occur. So when plans and providers are negotiating with each other, those particular elements get written into a contract. They actually dictate the payment terms. And so, you hear a lot about black box, and, like lunch was, I guess, a black box, right? Providers in particular want the glass box approach. They want to know, what am I being measured on? Where did you come up with this stuff? How did these codes come to be? So again, coming back to the idea of standards, if you have these sort of standard definitions and they're transparent, it gives you the opportunity to kind of set the right tone, set the right baseline for these arrangements. And again, the analytics that follow on behind that, right? So, at this point, you may be kind of wondering, okay, when are you going to get to the AI part, right? So that's, where we're going next. And, as we look at AI, some of the fundamental things, and you've heard a little bit about this in various talks already today, some of the fundamental things that drive into appropriate and effective uses of AI in healthcare really relate to the idea of underlying standards, transparency, trust in the output, right? So if you're going to automate something using AI, automating bad data with weak algorithms in a black box model doesn't really advance the state of the art in healthcare, right? So, as we look at the underpinnings in episodes of care and we say, how can we apply AI, and again, AI is a broad umbrella of things, but how can we apply AI in a way that makes the transition to value effective and drive that off of episodes of care? At the core, some of those principles, knowing what the episodes of care are, knowing how they drive good outcomes even without AI, and saying, how can we apply these in a thoughtful way to be effective, right? So, kind of transitioning from there then to talk about where there's opportunities. One is when we talk about population health, and we analyze populations underneath these episode definitions, we have to remember that fundamentally populations are made of people. And so, that may sound obvious, but One of the challenges right now in managing populations is that you manage an entire population. So in a risk-bearing contract, you may have 100,000 members, you may have 50,000 members, you may have a really big contract with 1 million members, and you analyze that entire population as a whole, and then you risk stratify the top 1%, 5%, and develop strategies to go after them. But in the end, there are a lot of these little subpopulations that are floating around within that larger population where, we don't really tend to surface those people, or they don't tend to surface themselves in standard algorithms. So that's one area where you can apply machine learning and analyze these larger populations, not just to say, what's the broad population that I want to look at and how do I address this broad population, but filter out these sort of subpopulations that may not be obvious to you, but when the algorithms start to pull data points together, they say, here's this population who's a little more vulnerable or didn't stand out at the top of the list, but is impactable in some way. And so in that sense, you can find these subpopulations where you can actually make an impact, sometimes even more so than your sort of top 5%. So, I used to run a couple of ACOs, and one of the things I'd always get frustrated by is we get these risk stratification lists out of our pop health system. We'd start at the top and we'd work our way down. And, number one on the list has metastatic cancer, and what are you going to do about that? Number 2 on the list refuses to ever go to a PCP and bounces in and out of ERs. What are you going to do about that? You can't make him go to a PCP, right? So, you start filtering out a lot of those people that are at the top of the list instead of sort of saying, well, who are those people that I can apply resources to that I actually could impact? Maybe they're not the people that show up at the top of the list, but they're those people who, don't go to their PCP very often, but maybe it's because they don't have transportation or they work late and they need after hours access, and that's the real issue, right? So you can use these kind of techniques to filter out those individuals and those subpopulations. And there's a lot of talk about health equity as well. How do you address care equitably? And so that's another sort of use case that lives underneath here, especially if you have demographic data. You have subpopulations that can also, again, kind of filter out and surface where you say, okay, well, here's this group that's being left behind for some reason, right? And what can I do to address that group of people in a way that's meaningful and effective? Now, when I think about value-based care, a lot of ACOs, and I'll editorialize, but a lot of ACOs are really focused on sort of playing the game, right? I risk adjust as hard as I can. I hit my top few utilizers, I manage referrals. There's kind of a playbook, right? But I think if you look at the spirit of the transition to value and the idea of being accountable and delivering care, ideally you want to provide that level of care to everybody. And so if you can find those subpopulations, if you can identify those people where you can say, well, these resources should go here, but these resources can be effective there, that's another way to sort of get deeper into population and give more care to more people in a cost-effective way. So, and I keep looking at my notes on my phone because it keeps going blank, but even the professor in the classroom has to cheat on the notes a little bit. So then going a little further, right, there are certain episodes that are just hard, and I'll use oncology as an example. Has anybody here ever tried to operationalize an oncology episode, out of curiosity? Nope. Okay. So one of the major challenges in oncology in particular, when we talk about episodes of care where there's a pretty clear definition, like a knee joint replacement, a knee joint replacement is what it is. It's pretty well defined and you can kind of wrap a set of codes and parameters around it. Cancer isn't. And so, a lot of times we categorize by sort of body part or body system, right? So colon cancer, prostate cancer, breast cancer. But there's a lot of variability within each of those types of cancer. There's different types of cancer, so to speak, in that subset. And then on top of that, the movement in cancer towards personalized care and aggressive care in some people means that it's hard to sort of put together a population. It's hard to really sort of clearly define, these are all the people with breast cancer, this is how much care they should get, and this is how you're able to benchmark outliers in care versus people who got the appropriate amount of care. So that's been a struggle really across the industry, trying to sort out how do we manage these more complex conditions? And that's where I'll say, when it comes to episodes of care and bundle payment programs, a lot of organizations are sort of moving away from bundles because they want to start to attack these sort of more complex disease states, chronic disease states with a lot of variability within the population, and it becomes difficult to do so. So that's where deep learning can kind of come into play, where, again, you can sort of identify who are these sub-cohorts within these larger populations in oncology or diabetes or coronary artery disease, right, where there are these definitions that are out there for episodes of care, but they just don't seem to work in really sort of saying what's the right amount of care, what does delivering value actually look like. So, in using those deep learning methods, they're not useful in the simpler sort of episodes, so the knee replacement types, but they can be really useful in these more complicated episodes or complicated disease states where you're looking to parse out really what's value and how are you going to subsegment those populations to be effective. Oh, no, you're fine. So, that's another area where as we look at AI and how you can apply AI, it's again looking for, you could almost call them edge cases, but they're really not because they're the bulk of care, and I guess this goes back to bundle payments and where in some ways those tend to be the edge cases, but the bulk of care, chronic disease management, it's hard to say somebody is diabetic and they fit into a neat definition of a diabetic, right? Because we have people who have much more complicated illness. We have people with secondary complications. They all need a different level of care, a different amount of care. So, then going beyond that, it's easy to say, yeah, well, let's use machine learning, and machine learning is great, and, we'll all win. Going back, though, to the principle that I mentioned earlier around transparency and standards, one of the real challenges, and I'll say this as a clinician, is this idea that really smart data scientists go out and create algorithms that I don't understand. I mean, I took math, but I had a calculator, right? I don't understand it. But I'm going to be measured, and somebody is going to tell me I'm a good doctor or a bad doctor. I've provided good care or bad care based on these algorithms that I don't understand and I can't see. But I got to trust the data scientists that, no, I'm telling you, they're great. They're really, really good, I promise. So again, for us, going back to the idea of standards, there are sort of open sources that are out there where you can go out and you can take something, and maybe it's not yet an industry standard, so to speak, at this point, but it is something that's open, it's out there, and it can be used by a number of people, right? So for example, we use in some of our software something called the explainable boosting machines, and our data scientists say it's great, but I think from my perspective, it's supported by Cornell University and Microsoft, and it's open. You can go online, there's papers published about it, you can see what the math looks like underneath. So you can say, okay, some number of people have looked at this, they've written studies about it. It's not just, one smart person with their laptop came up with this and says everybody else should believe it. It's something that's out there that you can kind of latch onto. And whether you're setting up the program as a health plan or you're participating in the program as a provider, you can kind of see where all this came from. And maybe you can't really argue too much about it, but at least you can understand it a little bit more. So, again, I think there's no standards necessarily out there when it comes to these kind of machine learning algorithms. But there are things out there where, standards bodies like this or just, professional organizations can get together and say, well, here's the handful that are public, they're curated, there's some degree of vetting that's occurred. Maybe we can't say these are standards, so to speak, but at least we can say these are the ones you can go to that people can latch onto and they can share and continue to develop off of. For us, one of the core things we do is we have in all our materials that go out to our customers, explainers of how we do the math, right? So, not just on a webinar with somebody, waving their hands, but you can download it and actually look, how do we do the math? Where did this come from? And then we'll sort of answer questions if they come up. Now, one thing I'll say, and I've had this conversation with our head of data science, there are more things we can do. We could be more rigorous, more precise with the machine learning that we apply. but it would be at the expense of transparency, because we then have to start doing things that are more difficult to sort of share with people or show people or explain. And so we've actually opted not to go down that path. So, in the end for us, it's more important that these things be effective than be just cool, right? So, in the sense of being effective, it is important that people be able to see what are the algorithms, to know there's papers written about them, to know there's some vetting that's occurred, not just once, but ongoing vetting for a lot of these things. And we want to share that with everybody who's using it so that we can be transparent about it. Now, I'll say that I won't name names, but I worked for a company at one time that it was actually the leader in clinical AI. And by the leader, I mean they had like 3% market share when everybody else was at 0.1%. So very, very early in the use of AI in a clinical setting. But one of the things I encountered over and over again, and a lot of our customers were hospitals. There were, some big, hospitals that you would know, some of you may even work at or have worked at in the past. The sort of complaint I got over and over again was, we don't believe your math, and so we would go over and over again and show them spreadsheets and graphs, and we promise like it works, and it's validated, and here's the P-score and all this, but they just didn't believe the math. They wouldn't use it. And, we could show them, I'll tell you one funny story. Again, I won't tell you which place, but there was a hospital that had deployed our tool for sepsis. And they were grumbling and arguing, we've done all these other things and our sepsis rates have improved. How do we know it's your tool that's helping, and they wanted a discount is where they were going with it. And so our leadership kept going back and forth. We'll show you the math. We'll show you why we're confident. And finally, they just got, sort of a little frustrated and said, okay, we'll just turn it off and see what happens. And, if you don't think it's doing anything, just turn it off, right? And at that point, everybody on the medical committee at that hospital kind of backed up and said, well, we don't know that we want to turn it off because it might be actually doing some good things. And, in the end, they kept it and they continued to have really low sepsis rates. So, I tell that story because I think as we embrace, AI and all things AI, on the clinician side, there really is a trust factor. And this idea that I need to understand, even if I don't understand the math, I need to understand that this is vetted, that some number of people looked at this and that I have the opportunity, if I so choose, to look at it as well and build trust around it. Now, I'll say that, the counterpoint to that is if we think about the AI that we use in other parts of our lives, like I got here by Google mapping from my hotel, right? I just inherently trust that Google is going to take me here. It's using AI to sort of calculate out the best route and tell me how long it'll take and that kind of thing. That trust has been built up over long periods of time with large-scale use as a consumer product. And so, I get that counterpoint sometimes where people are saying, well, but, I use Google, I use Amazon, and I use all these other things where AI is a part of my daily life. But, the difference is those are large-scale consumer sorts of devices. There's hundreds of millions of people on Google at any given moment feeding data into those maps and getting real time. We don't have that in healthcare. You might have 100,000 data points that are feeding in a batch file, once a month or once every 3 months that are driving that information. And so, that sort of level of trust hasn't developed yet the same way it has in the consumer environment. And that's something that, as we think about all the cool things AI can do in healthcare, that trust and adoption becomes critical because in the end, nobody sees value, right? Optimizing value. Nobody sees value unless we actually use these tools and we use them effectively to drive better care. Just having it on the shelf doesn't do anybody any good. So, moving towards then kind of some core principles for the future. And again, I see this body as potentially having a significant impact if it chooses to on kind of the direction we go here. One key principle is to look more at a glass box model than a black box model. And I say glass box specifically because you still need a box. It has to be defined, so you can't just sort of have this nebulous anything and everything. But having a glass box approach says we have clear guidelines, definitions, we understand what this thing is. You can see it. Maybe you can't touch it and mess with it because then it's no longer a standard, but you can see it and you can understand what it is as opposed to a black box. And so that, at least in my opinion, is the direction that makes the most sense for us when we think about standards as it relates to the adoption of AI. We're not going to get to a place where we're going to have these sort of open AI models where everybody's going to kind of make their own. Then we'll be moving away from the idea of standardization in healthcare and ensuring that everybody gets the best care or the right care. That kind of works in a Silicon Valley mindset when you're trying to create an edge in some other industry. But in healthcare, it's important that we're able to match consistency across the care that we give, and again, know that we're giving people the right care and effective care. So then kind of take another layer deep underneath that when it comes to standards, and I think there was a speaker this morning who was comparing blueberry muffins to chihuahuas. When it comes to the data that drives these algorithms, again, that's where there's an important opportunity. For me, I believe very strongly in standards, but I also tell people in healthcare we have non-standard standards sometimes, right? So, the reality is we have messy manual processes that sometimes occur on non-standard data, and sometimes we have to go in and manually clean it up. I remember I was CIO of a health plan at one time, and there was always a sort of crisis when it came to reporting our quality measures, because we would always go back and dig through our piles of data, and it might be like vaccines for one population in one town where there was a code missing, and we got to find that data set and figure out why isn't it there, what do we need to do differently. Or we'd find that, in this other place, the data was corrupt coming out of this one doctor's office. And if we go review that data, actually we did close all those gaps. We just need to go back and address it manually because the automation didn't work because the data was corrupt. So it's a constant manual process trying to go figure out how do I get standardization of that data for reporting and measurement and outcome management. So the more we embrace standards and standardization of data and really kind of building into our data platforms less proprietary and more standardized data models, the better the AI will be, the more effective the AI will be on top of it. So, if you think about the idea of the AI being kind of the cool stuff, everybody gets excited about that. It's not going to help anybody, and it may even do harm if it's operating on bad data and non-standard data. So, again, I think that's where being able to say, these are the standardized data elements that should be used in the context of an episode of care, for example, so you're measuring a service the same way, or in the context of some sort of algorithm that's being applied. That way we know that it's something that's been standardized and vetted, and that it can be effective in terms of the output going forward. So, I think about in terms of interoperability, and I know I'm at WEDI and not HL7, but thinking about the elements of a CCD, we have very prescribed elements that roll up into what's considered a CCD. Now we can have another debate about whether that's wholly effective in promoting interoperability, but it is what it is in terms of being able to then drive an effective sort of set of data where we say we know these particular elements with these particular standards drive into this broader standard. So again, here we have the opportunity, whether it's leveraging the episodes of care to say that we're going to use the same standardized data elements underneath standardized definitions, or whether it's just having a standardized sort of data model underneath some of these glass box algorithms, we can be practical and effective in driving standards, even if we're not going to be creating the standard algorithm, right? Maybe it's not feasible to create the standard algorithm because that all evolves so rapidly and changes so much, but to create the standard inputs so that we then have standard outputs that drive success. The last piece I'll mention is that when we move forward, a lot of what's exciting these days is prospective and predictive management. So I'll deviate a little bit from episodes of care for a minute and talk about risk adjustment. It's an area where I've spent a lot of time. Risk adjustment is inherently a retrospective action, and there's a lot of people that are sort of moving towards prospective gathering of data and becoming more active and being able to document effectively and make sure that you've got the right sort of risk profile for patients and members. But really where a lot of people are getting excited is predictive. Can you predict rising risk in a population or a subpopulation? it's hard. You know, I've worked myself on a couple of projects where we tried to figure this out, and I'm not ashamed to admit we couldn't do it. We tried. But one of the big barriers to doing that is that a lot of risk adjustment is done based on claims data, which is retrospective by nature and, you know, never really gets you to the level of granularity that you need to be effective in predicting risk. So, you know, a lot of what we realized was you need to begin to blend that claims data with, you know, lab data, with problems, med lists, things that give you further insight into what's going on with a person. And in particular, if you can blend those things together within a predictive model, you can begin to sort of identify rising risk. So again, going back to value-based care, you know, we sort of plan out a year based on data that we have and, you know, population analytics that we run. And so we're focused on the people who are chronically sick, who we think we can identify and impact and that sort of thing. What you never see coming is that person who looks healthy on paper because they don't really get health care and don't have a lot of claims, and then they have a stroke, end up in the ER and end up hospitalized for days, maybe weeks. Or that person who, you know, was pretty healthy and then all of a sudden now has colon cancer. And, you know, maybe it's fairly advanced and they're requiring surgery and radiation and chemotherapy. Those are the people you don't see coming. And so if you can sort of predict and see the rising risk that's occurring, that's sort of the new frontier. But in order to do that, like I say, you need standards both in terms of the data that you're using, standardization of that data to drive the prediction, and then also as you're applying some of the algorithms on top, the predictive modeling needs to be somewhat standardized as well, because if I'm racing to create the coolest predictor, I'm over here, somebody else is over here, who's right? I don't know. What are we going to do? So, you know, in the end, for a provider, these things have a material impact on the way I'm measured, the care I provide, and the way I'm paid, the way I keep my practice going, or if I'm a hospital system, the way I keep my hospital going. So, you know, it's important on a lot of levels to be valid and accurate and trustworthy and believable. So, you know, I'll close with saying, and then I'll open up to questions. You know, I'll close with saying, for me, when I look at where AI can be applied in terms of the evolution to value, it really is around areas where we can augment and typically not replace. So, you know, I don't know if anybody here is a Star Trek fan, right? I am. You don't have to raise your hand, but, you know, you're in a friendly room. You know, I still remember, I won't name the payer, but I went to it was a launch party that was hosted by a payer, and, you know, one of the insurance executives was, you know, really excited, telling me about this new device that was going to be able to do surgery without breaking the skin and how awesome it was. And I think he made a comment, you know, it'll be like Star Trek. It's so amazing. You won't need doctors anymore. The machines will do it. And I was thinking, every Star Trek I've ever seen has a doctor in it, right? So, but, you know, that really drives back to the idea that AI can augment what we do. It's difficult to replace, but definitely can augment. Part of the reason it's difficult to replace is medicine is evolving. We don't actually know everything. So we can't automate what we don't even know. But, you know, where you can automate and improve productivity, where you can impact a population of 100,000 and not just 1,000 by deploying resources, where you can, you know, impact episodes of care across larger populations of people, or create new episodes for complex disease states where you can break down those populations and be able to address people more specifically to some degree. Those are areas where we can improve productivity, we can augment capabilities, we can automate to reduce waste, but also, and I think this is something that gets blurred over quite a bit, we can create more consistency. So the problem with manual processes is that people do manual processes, and we don't always do things the exact same way. And we open ourselves up to human error, to problems, or to inconsistency in the way we operate. So, you know, by applying AI effectively, we can make ourselves more consistent. It's almost the equivalent of all going to the same class and training at the same level and being able to do the same things, understanding in the same way. It's easier to do that at scale when we start to automate. So, you know, that said, I think we've got about 4 minutes for questions before we end the session. So I'll open up if anybody's got any questions or comments you want to add.
Yeah, fascinating
Mhm.
subject.
Yeah.
that term is used in several scenarios, and I would be interested in your thoughts on who determines what value is.
So you're going to get me on a soapbox a little bit here, right? So,
That's what I'm hoping for.
Yeah. So, a lot of what's defined as value starts here in DC. If you look at if you're familiar with the HCP land, the Healthcare Payment Learning and Action Network, that's I think it's a not-for-profit organization that really creates definitions and measurement around the adoption of different value-based care models. But a lot of that is driven by financial payment models, and those financial payment models tend to start with government entities, with CMS, either through Medicare or at the state level through Medicaid. And if you look at adoption of those models across all different types of segments of insurance, it's very clear that Medicare is ahead of Medicaid, which is ahead of commercial. And commercial is actually flatlined. And ironically, commercial is actually the largest segment of spend across the industry. It's over $1 trillion, but it's kind of flatlined in single-digit percentage adoption of advanced APMs. And so, to your question, a lot of what's defined as value, I think, starts in a regulatory kind of way. It starts here in DC, and a lot of that is tied to financial models. I think where employers have not really stepped in, you don't see a lot of employers and only a handful of very large employers who have really embraced the idea of wanting to do value-based care amongst their populations. A lot of them were really excited about it early on and kind of retreated and just said, okay, went to their brokers and said, just give me the best rate. I just want to pay less money. Just beat them up and give me the best rate. So I think as you kind of go down the value chain, value to payers oftentimes is, tied into their metrics and how health plans are managed and, how they operate. So take it down a level again to providers. Providers are sort of operating in this environment where they're trying to align to the government and employers, the payer, and try to operate in a way that delivers value upstream to all those people. So I say all that to say I think the stakeholder who's not involved is the patient. And, I think when you look at the idea of value to the patient, or if you're a health plan to the member, I don't think the average person knows that they're even in a value-based care arrangement. They just know I get health care over here, and these people seem nice, and it's cheaper, So I think, that's where, and again, this is my opinion for what it's worth, right? I think that's where the opportunity is to sort of flip the alignment to say, what is it that patients want, that patients value? We have these sort of CAP scores and patient experience and that kind of thing that we measure, but we don't start necessarily by aligning value to the patient, then going upstream from there. We start upstream and then kind of go downstream to get everybody aligned in what feels more like financial alignment than clinical alignment. So.
Appreciate that. I think you're kind of spot on with that, because even in what you're talking about and what we're doing today is all based on financial outcomes and how do you get the best bang for your buck, as if we're shopping for healthcare like we're looking at the latest reviews for the latest Wi-Fi headphones or whatever. And to me, the value is, for a patient, is to get the best possible outcomes for their given healthcare needs.
Yep. No, I agree with you. So I think we're at 3:00. We're out of time here, but I'll hang out if anybody wants to chat. But thanks for the opportunity.
Notice this. So just a quick, we're about ready to break. First, on behalf of Summerpal, how many people can do this? There's your Trekkies. There's your Trekkies. All right, thank you. Hey, we have a break coming up. We have sponsorship by Pursuing Excellence. That will be, thank you for that. And we will be breaking from 3:00 to 3:30. Thanks a lot, everybody. Nice job.